Dr. Bijan Najafi.
Good afternoon, ladies and gentlemen. First of all, I would like to thank Canada and also the organizer of the conference, Dr. Casey, for giving me the opportunity to talk about the future of research about offloading. So these are the list of my disclosure. I'm a researcher, but probably the most important disclosure is that despite that I'm professor of surgery, I'm not surgeon. Actually, I'm an engineer by training, a lucky engineer that my primary appointment is in College of Medicine, Department of Surgery. So it gives me the opportunity to shadow the people like you to better grasp the unmet need and then try to facilitate translation of innovation from engineering to various clinical application. And definitely, diabetic foot is one of the areas that we need to pay more attention to it. I don't have any financial conflict of interest. So in the next 15 minutes, what I would like to talk about is about what are the research direction that I feel that we need to pay more attention, in particular in the area of the offloading. There are a lot of research that have been done, but actually they need to have more research, in particular in the area of the customization of the care or personalization of the care. Before going to the topic and discuss about offloading, I would like to ask audience, how many of you think that total contact cast is the gold standard and absolutely every patient with diabetic foot ulcer should be treated by TCC? Raise your hand. Anybody? Interesting. How many of you think that total contact cast may have some side effect for the patient with diabetic foot ulcer? Wow. Interesting. Okay, so this might be a little controversial topic, but often we need to have controversial topic to hopefully enthusiast research or trigger enthusiasts for research to do or to think out of the box and improve the quality of the care that we are providing to our patient. So first, I would like to talk about aging population. We know and we hear today that diabetes is a global epidemic, but we need to pay attention that we have a significant shift in demographic in every country. Our population become aging. So here is some of the number in United States. Currently, we have over 30 million people in United States who suffer from diabetes. But what is scary is that 40% of these population are older than 65 years old. In other words, every majority of the patient that you are seeing in your clinic, probably they are elderly people. We are hearing actually in the morning that actually somebody said that I'm treating a couple of days ago somebody that was 91 years old. It's a reality that we are dealing with. Now, some of the practice and guidelines that we have is really dated over 40 years, 30 years. The question is that, shall we personalize the type of the treatment when we are dealing with the aging population? So one thing that comes to our mind is that probably somebody who is frail and old and barely can walk, it may not be wise to put him on cement shoes. Okay, so and this is the reality that we have. Many of the diabetes shoes that we have and offloading, they are pretty heavy. So if you look at the CDC data, it suggests that if somebody has diabetes, most likely has a problem with mobility limitation. In particular, look at this data. If somebody is in the category of the 75 plus, this is a green diet, more than 80% of them, they have limited mobility. So the question here is that, shall we compromise the type of the treatment that we are providing for those patients? So let's discuss further in this area. This very nice study came years ago. It's a collaborative study between USA and UK, published by Ryan Cruz and WOCC, that they look at that what are the metrics that are predictor of speed of wound healing over next 6 weeks. And one thing that came out of this study is that the portion of activity for which offloading device worn actually is a strong predictor of the speed of wound healing. This is like a surrogate of adherence to offloading. It's a reality, no matter how good your offloading is, if the patient doesn't wear them, it doesn't work. So we need to pay attention about the factors that may contribute on the compliance to offloading. And they did actually a secondary analyzing, and they demonstrate that actually 2 important factors that are predictor of adherence to offloading is poor balance and foot pain. So again, we prescribe offloading, but we are not paying attention that whether a patient can wear them. So what we can do about it? This is also another part of the study that we did. We look at how offloading may impact gait. in patients with diabetes. So in this study, we have 3 groups. We have age-matched control group. We have patient with diabetes, peripheral neuropathy, and the patient who has foot ulcer and put them on offloading. So somebody who has diabetes, if you look at, for example, gait speed, already gait speed is reduced by 10%. But by adding offloading, we magnify by a factor of 3 this alteration in gait. And it's not just gait speed. If you look at the balance during walking, that is defined in the middle graph by gait unsteadiness, we alter balance by 80%, and we induce limp in our patient by almost 100%. So those are the challenges that we have in the patient, and yet we are saying that you should absolutely wear your offloading. So we need to do something about it. Why not? Maybe we can try to address limb discrepancy. So there are some simple solutions here that can address limb discrepancy, like Evanoff, or there are some new generation of offloading, like bilateral offloading, that we can prescribe to our patient. But of course, we need to have more and more research to see that how we can create offloading that provides or has less alteration on gait and balance for our patient. The another question is that whether the offloading should be knee level offloading. We are hearing actually the great talk previously that we said that maybe offloading should be knee level. So this is the question that we addressed a couple of years ago. We are saying that how about if you're cutting the strut height of the offloading? So here the study that you're seeing on the top figure, you're seeing offloading that we start the cutting from the knee level to above ankle level to below ankle level and compare to New Balance shoes. We find out that if we cut the strut, we can reduce the weight by 20%. But whether we can reduce the efficacy of the plantar pressure, yes, its impact on the efficacy of offloading. If you look at the bottom figure, when we have the knee level, almost there is no any pressure on the forefoot area. But when we coming above ankle level, we have a little pressure. Whether this pressure is clinically meaningful or not, that's depend of the level of activity. Now the question for our audience, why you think that knee level offloading is better than ankle level offloading? So actually one of the important mechanisms of offloading is shifting the weight from the foot to the leg. So if you have a knee level, naturally we have better efficacy of offloading. So why the ankle level offloading is much better than below level of ankle offloading? As you see here, the insole is exactly identical between these shoes, but still we completely lose the efficacy of offloading when we are coming below ankle level. A very important mechanism of offloading is locking ankle joint. So we need to lock ankle joint if we would like to have a good offloading on forefoot area. But now the question here is that where we should select knee level offloading compared to ankle level offloading. If you look at by losing the offloading by 20%, we gain 25% improvement in balance during walking. So now here is the question, maybe we should compromise, we should personalize the offloading. If you're dealing with somebody who walks 10,000 steps per day, you should go to knee level offloading. There is no any question about it. But if somebody walks probably 1,000, 2,000 steps per day, maybe we can come up with much lighter offloading. In other words, I believe that we should follow the guideline or the strategy of Nike. Nike now has shoes for walking, for jogging, for sprinting, for different type of the athletic activity. Maybe we should have the diabetes shoes or offloading for those who are standing a lot of time, those who are walking a lot of time, or longer period of time, or for frail or bedbound patient. So we need to personalize offloading, and definitely we need to have more research in this area. Another important aspect that Dr. Rogers briefly mentioned is that the activity does matter. That's true that the high pressure can delay wound healing, can end up to the diabetic foot ulcer. But a single step is not important except somebody step on a sharp object. It's a matter of the activity. When we multiply this pressure and shear by activity or by duration of the weight bearing, in that case it can cause some harm. There is unfortunately not much research in the area of the activity. I will talk about it later on about some of the new research. But we need to pay attention not just to the walking, also to other kind of the weight bearing activity. This is a study that we did a couple of years ago that we look at what are the configuration of the activity or the distribution of activity for the people who has high risk of diabetic foot ulcer, also those who has active foot ulcer. One thing that was very interesting to us is that duration of the study was 3 times longer than duration in walking, no matter that the patient has foot ulcer or not. In other words, they are not necessarily walk, but they stand for quite long period of the time. And yet we are not paying attention to these very important weight-bearing activity. How many of you think that this kind of posture, it could be risky for your patient with active foot ulcer or high risk of foot ulcer? Raise your hand. Yes, it looks very nice posture, but actually if it's happened for a prolonged period of the time, it could be risky for a patient. In other words, when we sustain those kind of the pressure, maybe for hours, in that case it can lead to ischemia, and in fact if you have bony prominence around the plantar area, it could be risky for the patient, it can end up with the ulcer. We need to have some research to address those kind of the prolonged or sustained pressure. And actually there are a couple of research that's happening. One of them is very close to you in the backyard in Calgary, a company named actually Orpex that finally pay attention to standing or sustained pressure. So they designed a smart insole, a smartwatch. What it does is that it detects the pressure that's sustained for 15 minutes or longer and right away send an alert to the patient. So in other words, they came up with a different way of management of the diabetic foot by engaging the patient to be part of health ecosystem, because the patient can take care of their own health. Currently, they don't have sensation on their feet, but if we provide them right feedback, maybe we can create those kind of surrogate for loss of the sensation. Another important challenge that we have in this area, as mentioned earlier, is reoccurrence of foot ulcer. This is a great systematic review published by David Armstrong, Andrew Bolton, and Sikobas, published in New England Journal of Medicine, that suggests that basically we are not healing patient. Maybe we heal diabetic foot ulcer, but we don't heal patient. Most of the ulcer happen with 40% within the first year, and if you look at 3 years, 60% of those patients we have reoccurrence of foot ulcer. So we need to do more research in this area. Maybe the type of the practice that we are doing for a patient is a part of the problem. We are talking about offloading, and as mentioned, offloading is not necessarily a short period of time. If the offloading, in particular the offloading that is used for locking the ankle joint, stay with the patient for longer than 4 weeks, that will lead to muscle atrophy. For somebody who is young, very active, they can quickly regain this muscle loss after wound healing. But for a patient who is frail, that takes much longer to regain this muscle. And then we alter biomechanics of the foot and increase more risk of foot ulcers. So what we should do about it? So we did actually recently a study to pay attention that what is the challenge associated with loss of the muscle lower extremity and biomechanics of lower extremity. So in this study, we have 3 groups of the older adults, the group who are non-frail, pre-frail, and frail. And then we look at the gait parameters. What was very interesting is that the most impacted gait parameters is during heel-off or propulsion phase. The patient loses the ability to lift the heel, and efficiency translates the ground reaction force to the velocity. So this ground reaction force transfers to the forefoot area. So what we observe is that actually the power during heel-off phase is reducing significantly by 45%, and that leads to a slower gait. Then we look at that whether that may increase the risk of reoccurrence of foot ulcer. This has not been published, we just presented in the Netherlands at ISDF. So what we observe is that actually those loss of muscles can significantly increase the forefoot pressure. Again, if you remember the formula in high school about the pressure, pressure defined by force divided by area of the contact. Force is ground reaction force, it's generated by body weight. But what's important, the area of the contact. During heel-off, the area of the contact is reducing, so the pressure is going very high. Now the question is that how efficiency we rotate the foot to efficiency translate this ground reaction force and transfer the weight to the contralateral side to relieve the pressure. So those who knows the biomechanics of lower extremity, they know that during heel-off, the foot should be rigid. If the foot is rigid, it can easily rotate without applying too much pressure. But if foot is loose, it's like rotating a sack of the sand. It's become much difficult to rotate the foot, and that can have some consequences for the patient, and this is what we find out. On the left side, we are seeing angular velocity of ankle joint during the heel-off phase, during propulsion phase. And on the right side, you see the same patient on green light is end up to green light on the pressure, and the red is end up to red. You see that the pressure is increasing significantly on the foot area when the patient losing the muscle. And this is the part that actually we need to pay attention. We need to see that if you're healing that ulcer, the intervention doesn't finish. We need to work to heal the patient. And that's maybe is another area of the research that we need to develop. How we should rehabilitate the patient, what we should do it after offloading. There's some very good research in this area. Currently the best evidence is exercise. Exercise is the medication for everything. But also there are some other generation of actually footwear intervention that's coming with promising results, like exoskeleton that help to activate the muscle in lower extremity. There are electrical stimulation. There are very promising results on electrical stimulation to actually improve plantar sensation. And also there are now recently new offloading and new actually insoles that help to activate lower extremity and improve the perfusion. Exercise, exercise, exercise. This is very important to promote exercise, and there are very good low intensive exercise. Exercise does not mean that the patient should go and run on the treadmill. A simple, even non-weight-bearing exercise could be very effective. This is a systematic review that we have done that shows the benefit of variety of the exercise to strengthen the lower extremity. It could be as simple as grabbing a tissue with the toes when the patient are sitting. Of course, the challenge is that engaging the patient in exercise is very challenging, but now we have a new generation of the technology that can address this challenge by gamification of exercise. So this is a recent study that we have done for hemodialysis patients. These patients are coming 3 times to receive hemodialysis. They are sitting there for 4 hours. That decondition the patient, increase the risk of foot ulcer because of rigidity of the joint. So in a recent study that we have done, actually with collaboration of Qatar in Doha, we find out that just if the patient playing a simple game by movement of their feet, it's like the game of Ninja Fruit. How many of you knows this game? So quickly you move and cut some fruit. So this is the same thing that the patient love it actually. They have some songs, they beat the score, so they are goal-oriented. And actually we demonstrate that these simple games is effective to improve balance by 30%. So finish here. So the key takeaway point. So we need to pay attention to aging population. The demographic is shifting, and we need to also adapt or practice. We need to promote personalized care for a patient. We need to pay attention with limitation of the patient to wearing the offloading. Adherence is a major challenge that requires to have more research on this area, as well as prevention of reoccurrence of foot ulcer. But there are some promising development in the field, from the footwear, from electrical stimulation, from personalized offloading. Of course, definitely we need to have more research in this area. Thank you so much for your attention.